here to speak, even as the last speaker. I'm going to talk about some economic theory today. It's on the issue of market failure theory, and it's been also published early this year as a chapter in a book by the Swiss Libertarian Institute. It came out this year, and it's a collection of libertarian essays on practical steps to reform healthcare. So if you want to read the German version, you will find it in here. As you can see, I'm a medical doctor myself, and grew up and I was trained and practiced in Switzerland. Apart from that, I studied health economics, mainstream health economics, and of course, I'm a student of the Austrian school. And of course, these are two areas that conflict each other quite a bit. And when you talk to health economists, they will say, the market for healthcare does not work. That's based on some concepts I will outline later. But it's a widely used theory to deny marketability of medical services. And that's a real big problem. And I see it practically, every day when I work with clients. I often see that there are situations that are totally marketable. You can put a price tag on it. You can compare services and situations. And there's no reason it's not marketable. Yeah. So I had this idea that something's a bit flawed with the market failure theory, and within the Austrian economics, there's not really a take on health itself. So, before I talk about the market failure theory, I want to say a few words about healthcare itself, because even the word itself, it's not very useful. It's a bit fuzzy, what is healthcare? It's no discrete thing. You can buy it or consume it. It's rather a very diverse bundle of different goods and services. Like treating infections, treating mental health, or allergy tests, or surgery, or whatever. And they often have very little in common. And it's doesn't make much sense to put it under one big umbrella and say this doesn't work on a market. And so please keep that in mind for later on. Now if we look at healthcare on the practical side, then what happens in a healthcare system, the delivery system, those are the doctors, usually the doctors and some health providers. You see them here everywhere, and they are usually licensed doctors, and they're part of a professional organization. And it's professional organization you have in every country. Usually it's one kind of guild, a guild network, and usually it's a monopoly. It's a monopoly. The certificates hands out certificates for doctors who follow a certain curriculum, and it's anything but a market order or a spontaneous order that happened on the supply side. So, for example, a doctor who sits here is a primary care doctor. He does the job of allocation. So he says, you have this problem, you must go there. Or, for example, the job of a radiologist who assesses brain scans. That's a mere product of the medical professional establishment. It didn't happen on the market. It's a result of organized medicine, how I see it. And you see, it's a bit of a bad starting point for talking about marketability, because we're already on a level of a lot of regulation and intervention and subsidies. So, of course, we have, if you talk to health economists, they will say, the market doesn't work just because it's too regulated. But that, of course, is a result of previous intervention. Then they will say, everybody should have access to healthcare. And it sounds reasonable, but I think to you I don't have to explain, the flawed concept of equality. So I move on, to the market failure theory, because it's convenient for health economists to say the market doesn't work, because then they can say, well, we need to regulate it, we need to research it, we have to do econometric research, like cost utility studies, cost benefit studies, to guide politicians and plan out the system. So the result will be that you're saying the market doesn't work, so we have to put everything that concerns healthcare in a box here and put the third-party payer on top, and that's usually either a national health system or it's health insurance, which is normally not really insurance but rather an income redistribution scheme. And this makes it very complicated to work within the system, because it becomes very rigid and formalistic, because you lose prices as signals. The third-party payer will have either a set of fees, or there will be budgets, but there will be no pricing between patient and provider. So you lose this allocation, and you lose a feedback mechanism because prices don't adjust. It becomes really bureaucratic, and that's that ends up in a big mess, as we can see in many healthcare sectors. So now let's talk about the theory of market failure. It's actually something that grew out of welfare economics in the 50s. That's part of neoclassical economics, and it's based on the idea of an ideal market in which you have perfect competition, perfect knowledge of supply and demand, and homogeneous goods, and instantaneous equation of market processes. So in itself, it's already a very idealistic, or you can say utopic model, from which they would say then, compared to the model, the real world doesn't stand up to it. And the basic, if you look at the health economists textbooks, they will still write about a very old publication from 1963, Kenneth Arrow here, who wrote a paper in which he outlined the reason why the markets don't work in healthcare. And I'm going to outline a few of them here. So as you heard before, there's a regulated supply, so there's no free entry into the market. It's unlike any other commodity. Then they will say that health or disease is different to any other commodity good, because it can happen by chance. You don't know when, you don't know the course of it, you don't know how treatment efficacy will be. It's really unpredictable, and you have no idea about the costs that's going to happen with it. And also the patient himself is very vulnerable when he gets ill, so he can lose his working ability or decision-making ability. So what he refers to here is mainly unpredictability of health, and then he extrapolates it, to every kind of healthcare situation, saying that it's too uncertain to let the patient be at the mercy of the doctor and negotiate the price. And the third reason is usually there's information and of asymmetry, as we've heard before, which means that the doctor has more knowledge and experience himself, and the patient has no consumer sovereignty. He doesn't know what he needs, what test he needs, or what treatment he needs, and also in a way, he's unable to acquire that or learn that, which of course is a bit naive to think. And then the fourth point about the market failure theory, has to do with the specific characteristics of the medical profession. The doctor is unlike a businessman. His primary goal is to take care of the patient, the well-being of the patient. He advises him, but he also does orders tests on his behalf, and there's an element of trust and relationship involved. So he's not just a salesman. He's about to take care, and it's actually something that will be reflected in his reputation. But the idea here was to say the doctor shouldn't concern himself with pricing business services. So it's better to have it regulated and let somebody else take over that task. Now, not for the sake of time, I cannot go into every detail here, but I want to point out this faulty idea of information asymmetry, which of course sounds reasonable and impressive, and a doctor has a long time of studying, but in a way it's everywhere in life. Nobody has an equal amount of information, and actually, if you look at it in another way, it's a precondition for the existence of markets, because if you have a specific skill, then you have to be an advantage to sell it. The teacher has to have more knowledge than the student in order to offer his service. And the software programmer must have skill and knowledge to offer his service on the market. So of course the knowledge of the doctor has always been part of his job, and it's also like what makes the division of labor and knowledge possible. But what they are more concerned of, within this asymmetric information, of course, is the abuse of power. That somebody, if you're in a vulnerable state, the doctor can take advantage of you and beat you extensively and work in his own profit motive, and thereby, it's not possible to put a price tag on it. But of course, the markets have instruments how to prevent the abuse of power. We know that. For example, a lawyer also has this problem that his client cannot know how good his service is, and it's uncertain how it ends up, and it can be devastating to his life. So, yeah. Okay. So the market works by reputation, second opinion, or intermediary agencies, which are supposed to provide additional information here. And if you're abusing your power as a doctor, and the patient will find out, the word will spread, and if you lose your reputation as a doctor, you're gone as a professional. Yeah. So another problem here is if information asymmetry is subsidized. If you take like 6 years medical training, which costs $500,000 Swiss francs in Switzerland, and then you put another certification by the medical monopoly on it and the medical jargon. This will give you an image of, it's a unattainable competence by the doctor, where very often it's not the case, and the patient here will stay kind of helpless because he thinks, medicine is a mystical endeavor, I will never get it. So it's subsidized anyway. let's hand him over my responsibility. So if you the story is, if you let the government intervene and the guild run its show and the healthy economists take over, then the barriers to entry will grow and will rather look like a fortress as it is nowadays. Organized medicine, and it's really hard to enter there. It's really hard to change processes or to bring in new innovations compared to as it was in the centuries ago. Yeah. So that was my ending remarks. I think I'm good in time and have some time for questions. Please.
One or two questions, please. Short questions.
How would you propose to sort of even out the information asymmetry? You talked about it's not so much that medical knowledge is mystic, that people can acquire it and then make judgments based on that, but what do you see as a real solution to that asymmetry?
Well, it's kind of, it has to be there, it cannot be equalized, but in every state of disease it becomes a journey, to know as much about your own state. And most people, of course, they have more information than the doctor about their habits and their past, and they sort of need the doctor, to equalize the information. So you go to the doctor and you talk and you ask him what can you tell me, what's the knowledge. So of course the doctor can be a source of evening out information asymmetry here. But still, it's a lifelong task. Yeah? And there's a lot to learn, handling the body and the mind.
Yeah. What do you think about the feasibility of a voucher system for medical care?
What do you mean exactly?
So the government giving money for people to choose what medical care they wish to have. So as a voucher.
By voucher.
By voucher, yeah.
Yeah, I think it's still better than redistributing income or having a national health system. What we're proposing here in the book is to have a very high deductible for health insurance, and you have subsidies to poor people still, that's similar to the voucher. So still it's better than what it is now.
Isn't all insurance in some sense a form of redistribution? I mean, those who often need to use it, those who don't.
It's just a matter of if it's a coercion, if you have to buy into insurance or not. Because the one I mentioned is not insurance in the sense that it's private and voluntary. It's called, here in Europe it's called insurance, but it's like a collectivist scheme.
Okay, thank you very much for participating in this session. Now enjoy the lunch.